I would like to thank very much the organizing committee and my chairs for giving me the opportunity to develop two lectures. The first one is the ERS guidelines in rare diseases, as you see here. The last 3 years, I had the honor to participate in two task forces of the European Respiratory Society, both of them associated with rare diseases of the lungs. The one is the transition statement on pediatric patients with interstitial lung disease from pediatric to adult care. And the second one is the ERS clinical practice guideline on diagnosis and management of pulmonary alveolar proteinosis. Regarding the first one, the paper actually was submitted and accepted in the ERJ a few weeks ago. So we are allowed to discuss about our results. Regarding the second one, the guidelines for the pulmonary alveolar proteinosis. Until yesterday, it was under review and it was accepted yesterday at the ERJ, but I'm not allowed, it's not published yet, so we have the embargo and we cannot share. We do not have the time as well to discuss on two papers, so we will focus on the ERS statement on transition care in childhood interstitial lung disease. We are adult pulmonologists, we're very familiar with interstitial lung disease in adults. We know that ILD in adults are a heterogeneous group of non-neoplastic disorders resulting from damage to the lung parenchyma by varying patterns and combinations of inflammation, immune dysregulation, and fibrosis. This is one of the most recent classifications. Because we do not have a lot of time, I will not focus on that. We are all familiar with the classification of adult ILD. On the contrary, we wonder sometimes, the adult pulmonologist, that we are experts in ILDs, we are considered as experts on ILDs in adults. Do interstitial lung disease exist also in children? They do exist. Child covers a heterogeneous disorders, and they're much, much rarer than the adult ILD so far, 1 to 8 children per million of children, but they are increasingly recognized the last few years. The pathophysiology of children's interstitial lung disease often involves a genetic component, sometimes exposure-related injury or autoimmune dysregulation, and sometimes there is no etiology, no matter how much we're looking for it. So there are many classifications for children's interstitial lung disease. The most prevalent, I would say the most widely used, is the classification by Professor Matthias Griese. It's the classification that is made by the European Management Platform for Childhood Interstitial Lung Disease. As you may see, the table here is not very clear, I would say, but all the entities of the adult interstitial lung disease are included in the children's interstitial lung disease, plus some other entities with whom we are not very familiar, like the developmental disorders, like the neuroendocrine cell hyperplasia of infancy, the diffuse parenchymal lung disease related to lung vascular structural disease, and the diffuse parenchymal lung disease related to immunocompromise and to lung transplantation. This is our statement. The only reason I'm showing you the first one page is because it is like every ERS task force, a very collaborative work, very hard work, but very rewarding at the end. Many members were participating from countries all over Europe, not only physicians, but also methodologists, psychologists, and representatives of the patients. We all know that children's interstitial lung disease is no longer purely a childhood issue, as many children survive into adulthood, and so they have to transition from pediatric to adult care. We also know that transition is a very, very important step at the life of a child with children interstitial lung disease, because it has the potential to impact on physical and mental health outcomes. So this is why we started to work on this statement, because we know that children with interstitial lung disease always need centralized pediatric specialistic care because of the rarity and the diversity of the conditions included in the classifications. We know that many of the diseases of children's interstitial lung disease have a genetic background, so we need to get familiar with that. The course and the prognosis so far, it's not very well studied. It may range from lethal respiratory failure at birth to fibrotic disease in early adulthood. And if remission occurs in children's interstitial lung disease, they always have residual impairment of lung function, and there is always a risk to relapse. This is something that we need in the future to study more and to get familiar with this. Although there are transition programs in other diseases, the most prototype disease, I would say, is cystic fibrosis. Nothing is done so far regarding children's interstitial lung disease. There is insufficient support during transition to adult care, and that means that many of the children with serious problems will be lost from the care of the adults. So this statement describes the current evidence on best practice of transition of care in children with chronic interstitial lung disease, contrasts this with current clinical practice, and identifies, very importantly, areas for future research concerning transition of care from pediatric to adult specialistic care for ILD. I will not focus on the methodology of the statement. You all know that every task force of the European Respiratory Society is based on exhaustive, I would say, search of the literature. So it's an evidence-based statement. And of course, the expertise of the participants is always taken into consideration. We had 5 questions to answer. One was a PICO question, a PICO question. A PICO question is a question that addresses an issue about the patient with an intervention. It compares the patients who had the intervention versus those who did not have the intervention, and then we check for the outcome. And the main question of the statement was, does participation of children with a chronic respiratory disease in a care transition program leads to a better outcome? And the answer was yes. So participation enables a more successful transfer. Why? Because it lowers pre-transfer anxiety, it significantly improves transition competence and readiness, self-efficacy and independence, as well as satisfaction with school and educational issues. Overall quality of life and health-related outcomes for children that participate in a transition program do not worsen, and in some cases they ameliorate. And the benefits of the transition program are not only observed in patients, but also in their families and their parents. So the second question we are asked to answer was, which care transition programs are currently used in clinical practice for children with interstitial lung disease? Because we do not have a lot of time, I will answer to you that there is no such program. Very few countries actually have an organized method for transition, but not in a systematic, official way. There are many questions about the ideal age of transition, whether it should be at 18 years. There is a range between 16 and 21. The availability of multidisciplinary teams to participate at the transition program, the pre-transition meeting with the patient, parents, and both the pediatric and the adult teams, the long-term follow-up of children with children's interstitial lung disease specific for early age. Sometimes these diseases remit in later in the child's life, and these people remain without any follow-up in adulthood. And there are many questions regarding also the reevaluation, the need to reevaluate children's interstitial lung disease when they transfer to adult care. We formulated a proposal about the minimal content of a transition report that has to be included in the transition process from the pediatric care to the adult care, including many information about the diagnosis, the documentation of the disease, the treatment, the pedigree, the family, and the prognosis of the patient, as well as many socioeconomic and psychological aspects of the child. We know that there are many transition programs in other diseases, chronic diseases, like rheumatic disease, inflammatory bowel disease, neurologic diseases, long-term ventilation, but nothing from child. What we learned from these transition programs when we went through all the literature about them as a task force was that an important goal of transition is to empower patients and families and increase autonomy, patient participation, awareness, and consciousness, as well as the development of relevant psychosocial skills. An organized process is very important, and without such a process, young people, even with very complex entities, are lost to follow up with detrimental outcomes regarding their health and their quality of life. Transition planning is a multidisciplinary process. This is something that we pointed out in this statement. And many of the complaints of children and families with a chronic disease is that there is a lack of a specific transition coordinator. There is a generally haphazard timing of first discussion about transition, and there is a lack of involvement of psychologists and social workers to help the patients and the families to the transition process. Of course, when we are referring to children's interstitial lung disease, we know that we're referring to ultra-rare diseases. So it may be difficult for every center to have a specialized transition program for children with interstitial lung disease. And there may be also difficulties with regard to selection of the appropriate adult expert center, especially for those entities of child not well known to adult ILD experts. And here there is an issue of training that I will discuss later on. The fourth question was, is there any evidence of long-term remission of children's interstitial lung disease? In order to discuss about transition, we have to know the natural history of children's interstitial lung disease, which are many heterogeneous entities. They are entities that present with spontaneous remission, like non-fibrotic hypersensitivity pneumonitis in childhood after removal of the causative agent, like neuroendocrine hyperplasia of infancy, like pulmonary interstitial glycogenosis, like sarcoidosis, like organizing pneumonia. There are some other entities of childhood that have partial remission. So these people will survive into adulthood and may be functionally impaired. And there are some other children's interstitial lung disease that may lead to end-stage fibrotic disease that may need evaluation even for lung transplantation at very, very early age. So these data confirm the necessity of continuous patients follow-up from childhood to adulthood, and the risk of relapses later in life remains to be elucidated. And the final question was, does the current definition of children's interstitial lung disease versus adult interstitial lung disease influence transition of care? Do adult pulmonologists, specialists in ILDs, speak the same language with pediatricians that are specialists for interstitial lung disease in childhood? The answer is no. There is a lack of harmonization between the current adult ILD and child ILD classifications on transition of care, and this affects negatively the transition process. We need to speak the same language in order to make an ideal process of transition for these children. To conclude, I have to say that what we learned from all this literature search and from discussing between experts and what we stated in our statement is that it is a good plan for adult physicians to gain the confidence of the young person before making any treatment changes, unless this is absolutely essential. Patients with children's interstitial lung disease would optimally be managed by doctors specialized pulmonology or pediatric pulmonology with special expertise in children's interstitial lung disease. Rare pulmonary diseases require expertise with specialized pulmonary investigation methods and specific treatment options, and the expertise of specialists in adolescent medicine who can address also issues, psychosocial problems related to transition or adolescence itself is also very helpful. For example, issues of substance abuse, social autonomy, sexuality, or professional orientation, so that there is a role for them in a multidisciplinary team that will be dedicated to transition of a child. What I would like to say as a final slide in this presentation, and what I realized through this very nice statement, is that we need to apply collaborative strategies, the adult ILD physicians and the pediatricians, and have a constant training on interstitial lung disease in children. We are not so familiar with these diseases, and we have to learn a lot by studying them and by constant training. And I thank you very much.